our co-hosts to join. Oh, perfect. I see Brad. Brad, do you want to kick off with overview of the ground rules?
I would love to. And sorry, I was having a slight Zoom issue there. Hopefully everyone else is on successfully. But yeah, just wanted to welcome everyone and then just briefly review the ground rules. And so welcome to the Maternity Bundle Provider Forum. And so, we definitely value your time. So we're going to start on time and end on time today. This will be recorded and we'll post it to the DSS YouTube channel for viewing later. And if you're not speaking, please make sure to mute yourself. Use the chat to identify yourself by entering your name or organization. And otherwise, please limit the use of the chat for Zoom technical and audio issues only. There's a Q&A feature, and post your questions anonymously using the Q&A functionality. This forms will be posted on the Maternity Bundle website, so you'll be able to find those hopefully relatively easily after this meeting occurs. So I think we have our agenda and we'll get started. So just a little bit of what we're talking about today. So today is the program Go Live update at the start. We'll talk about the bundle overview. It's a bit of a reminder about what we've developed so far. Talk about provider attribution, some target price reconciliation, and then quality measures. At the end, there'll be opportunity for questions and answers. So we'll look forward to hearing from you, all of you, on questions that you have, and hopefully we'll be providing you with some updated information to inform all of you on the status of the launch and updates to the bundle itself. So the program Go Live update, I suspect many of you have heard this, but we had initially planned on implementing this in January 1 of 24. However, after a lot of discussion for several reasons, we're pushing back the launch until September 1, 2024, pending federal approval. But we also note that we may be able to launch earlier than that. And we are going to give providers 3 months notice if we can launch earlier than September 1, 2024. The decision to launch was made after a lot of internal discussion based on several factors, including the need for further engagement with CMS. There were some delays in engaging with them to get approval. There's some further programmatic refinement and development that's ongoing at this time. And we also want to make sure we're doing adequate stakeholder engagement. We know there's been lots of questions about the bundle, how it's working, and also getting all of you information about, especially providers information about the impact it will have on you. So our next steps are really getting the CMS SPA approval, the state plan amendment, that's what SPA stands for, approval, finalizing actuarial modeling, making sure program's ready, finalizing those key details. And then some upcoming work that will be happening is a provider FAQ, provider bulletin on the policies and processes, the program testing, dry run of using historical data, using historical claims data from 2022, and then reports based off of that dry run. And then additional provider forums with you, as well as our advisory council that we met with recently and provided an update to. Next slide. So the maternity bundle overview, and again, so I'll be passing this off back and forth between myself and a few other colleagues. I'll be covering this first section here, but episode-based payment. So why are we doing this? And so historically for maternity services, we've paid a fairly traditional fee-for-service mechanism. And so this maternity bundle is moving towards a episodic payment, where we're moving towards incentivizing quality over volume and really trying to encourage coordination over that course of the entire bundle. And some of the reasons are, increased efficiency, coordination, as I mentioned, the improvement in care quality and outcomes, and trying to reduce unnecessary costs. We can go to the next one. And again, this is a kind of a refresher based off of things that we've discussed before. However, if there's any questions about anything that's said or not said, feel free to put it in the Q&A towards the end. Excuse me. So this is an overview of the bundle in terms of the timeline. You'll see that it goes from, on the left-hand side, 280 days prior to delivery. And if you look, you'll see a little green box. In that first trimester, we'll continue to pay fee-for-service payments to outpatient providers. Excuse me. After that first trimester, we'll move into the second and third trimester. We're going to have a bundled case rate payments. Sorry again. Actually, let me take one moment. Tiffany, do you mind if I pass it to you just for a second? And I'll take back over. I just want to get a sip of water so I'm not coughing on this.
So this slide is really just to provide an overview of the episode of care, in which it's going to span the entire maternal perinatal phase from pregnancy all the way to delivery and postpartum. So what you can kind of see, just to provide a brief overview, you'll see for an early portion of the pregnancy, which will be the first trimester, all care will be paid for through fee-for-service. Starting in the second trimester, there will be the opportunity to trigger and start earning bundled case rate payments. There will be more information about what services are included in the case rate payments. And then, of course, throughout the rest of the episode into delivery and postpartum care, payment will continue on throughout this episode. At the end of the episode, there will be an opportunity for shared savings opportunities, which we will go through later. But this slide is really meant to show a breakdown of what the episode will look like and provide a little bit of an overview about the services that are going to be covered. Brad, is there anything you wanted to add?
No, I think that was great. And thank you for helping me out there. Recovering from a slight viral illness that still some lingering coughing going on. So apologies, everybody. And luckily we have a lot of experts on this, so I know good hands with Tiffany, but I think that's an overview. Oh, go ahead, sorry.
Oh, no, go ahead. I was just going to say, I'll just say we're figuring out the Q&A function. So in the interim, we'll allow people to use the chat function if questions do come up as we're presenting.
Great, thanks for that note. So I think we can go to the next slide then. Great, so accountable providers. So as we think about the episode, who are we accounting the episode to? So in this case, it's to outpatient obstetric, OB, licensed midwives, as well as family medicine providers that meet the minimum volume criteria. Minimum volume criteria is 30 episodes in the past 12 months. And so this can be attributed to provider groups holistically, not just a single provider. I think we've covered a lot of these materials previously, so I won't get too much into the details on it, but I just want to note that for the attribution, part of this is getting attributed for how we pay. So again, that first trimester is that fee-for-service payment. We then transition to this case rate payment that will occur on a monthly basis, and it requires providers in the outpatient setting to trigger that using triggering diagnosis codes to start that payment. I think that's probably the most important thing to note here. I think we can go to the next slide. This is just how we're going to handle multiple births, newborn care, postpartum care. So newborn care in year one, we won't be including the care in terms of the costs and shared savings, but we'll be monitoring 30 days of newborn care and provider reporting. So we'll provide the data, but we won't necessarily be holding providers accountable to the cost of it. However, over time, we do plan to phase in newborn care for accountability after year one, potentially in year two, though that's still to be determined. In terms of postpartum care, there'll be 90 days of postpartum care in the for financial accountability. We'll be reporting out, thinking about 365 days and thinking about what's the right time period, but in at least 3 months starting with 3 months postpartum. For multiple births, we'll be including that multiple births in the prospective or that case rate payment based on a singleton birth. However, at the end, since we'll be paying on a singleton birth case rate, we'll be kind of truing up or effectively paying fee for service after we do reconciliation. The reconciliation is that process at the end where we add up costs and we kind of make sure that what payments were made when and to who, to make up the difference for providers between a singleton and multiple birth. So that will be made up for in the end. And I think we'll go ahead and move on to the next one for now. And this breaks down the different pieces of the episodic design, what's included underneath this bundle or episode, and what services are included where. So you'll see that on the DSS approach, you'll see the column include in bundle under A1 pay prospectively. These are services that are going to be provided in the outpatient provider, maternal health provider's practice on a normal basis is what we anticipate. And this will include it under the case rate. These are things like professional services by the OB, nurse, licensed midwife, or family physician. It's the same thing for hospital-related costs that are for the attributed provider. This would be for screening related to behavioral health, but not treatment, in-house imaging, diagnostics, labs, as well as potential doula services, which we'll get to a little bit later. I'll move on to A2, which is things that are included in the bundle but are settled retrospectively. Again, the retrospective piece of this happens after the bundle or the episode, so it's after the 90 days postpartum. These are all the things that get added up into the costs. This includes birth center and hospital costs related to maternity, specialist professional services related to maternity, general pharmacy, OB midwife, family medicine provider, imaging and labs outside of the practice, so things that might happen in a hospital outpatient setting or independent lab or radiology. And then under B, these things are excluded from the bundle. So they'll be paid in their traditional way, and there's no financial accountability. So those are things like pediatric professional services, NICU, behavioral health and substance use services, LARCs, long-acting reversible contraceptives, sterilizations, DME, high-cost medications like HIV drugs, and hospital costs unrelated to maternity, maternal oral health, and some other care. So these things are excluded again from the retrospective reconciliation. They don't get added up to determine what that total cost would be. We'll get to a little bit more of that later. I'll pass it off to my Mercer colleague shortly. I think we can go to the next slide, where we'll talk a little bit about doula services. So this is an important part of how we've thought about improving care, is making sure there's doula access. And there's a kind of no wrong door approach is how we're building it out, where there's two opportunities as of now for members to get access to doula services. One is paying doulas directly through the maternity bundle, and two is paying doulas a fee for services for enrolled providers or enrolled doulas directly. So on the left, you'll see number one and number two. One is paying through the bundle, and that envisions the outpatient maternal health providers who are accountable getting paid for doulas, and then those providers paying doulas with those dollars. Under the two, paying for fee for service, this would be again this is doulas who directly enroll with DSS, and we would be paying a specific fee for service. This is pending DPH finalizing certification for doulas. That I don't believe has happened. It could happen at any time. We're still waiting to hear about that. And then DSS will, on our end, once DPH has done that certification, will have the process in place, which we are still working on and not sure of an exact launch for when we could enroll doulas and how we will go about doing that. So just to say, there's two pieces. We want to make sure members have access to doulas, and we've worked closely with previously with PMC or primary maternity care to help us start think through that process. I'm going to pass it over to, I think, Grace and Charles on the Mercer team to talk through a bit more, and then you'll hear from me in just a little bit.
Thanks, Brad. And I'll take us through the next few slides and talk a little bit about the payment and price structure, as well as the attribution, and then pass it off to Grace Yang, our actuary. And so this also is a slide that has been visited before, where we've described the target price, which is the baseline performance price that we are expecting the accountable providers that do make it to reconciliation to be judged against. That baseline is going to be risk adjusted so as to put all the providers on an equal footing, risk adjusted in a couple of different ways, specific to hospitals as well as some other services. Those are coupled with the prospective payment. We've talked a little bit about the prospective payment and how it's triggered and what services are categorized. We'll talk a little bit more about how that plays in. all going to the two components that are relevant to the reconciliation, which is the retrospective look at actual costs, the target price, plus the prospective payments that are garnered through the case payment along the way. We can go to the next slide. And so the case rate payment methodology, what we are trying to do there, identify the services that are happening at the core OB that is managing the episode. What we want to do is be able to build out a case rate that is comprehensive enough such that we could give the payment for any episode to the case, to the attributed provider, and it would make them whole for specific services. Over on the right is the table of services that you see, the pregnancy. Of course, those services are included in the case rate. The delivery, no, that is separate, but is included in the retrospective reconciliation. And if I'm saying that too fast, we'll kind of revisit it again in a few slides and talk about it a little bit more. For the postpartum care, that's the services that happen after the delivery. Those will be included in the case rate payments. The case rate payments will be derived using an algorithm that takes the entire episode costs, but breaks it into prospective payments afforded to the attributed provider. I'll take a step back there and say there are the attributed providers, which are the ones that receive the case payment along the way. And then they may and may not become the accountable provider, which is the one that is held to the reconciliation. That is where the target price comes in. We can talk about that a little bit more. But for the case rate payment, it happens to the attributed providers that have a triggering claim diagnosis attached to one of their claims that then triggers the prospective payment. And I'll talk a little bit more about how that goes in the following slides. We can move to the next slide. So in determining the attribution and deriving the process, which we have been revisiting lately to make sure that the case stays with the providers that we believe are most accountable and in the best position to affect the outcomes of the maternity episode. So the principles they're outlining are that we keep them with the core OB, that we keep as many episodes in with the accountable providers and make it all the way to reconciliation so that all the episodes in the aggregate for the opportunity for each of the practices to garner some of their shared savings. We are working on designing the attribution to appropriately addressing co-management of episode. That is where a OB is accessed and then perhaps a specialty care is brought in for the somewhere over the course of the episode. And we're designing it such that it can accommodate both the specialist or the visiting provider, as well as the core managing OB. And then also removing accountability from those OBs that are attributed and managing the case, but the case or episode eventually moves away from that OB, such that OB in the reconciliation process isn't held accountable for services where the episode is actually moved to another care provider. And so one of the attribution rules that we've derived is that the last in chain in the second trimester is most likely in the position to affect the outcome of the episode. So we're taking the attributed provider last in chain in the second trimester, and then we will look to the third trimester to see if they maintain care through the third trimester, and if they do, they'll become an accountable provider that is then that episode is then part of their total reconciliation. If that episode moves in the third trimester, we would remove them. We will remove that episode from their accountability pool or their reconciliation pool. And we can go to the next slide. And what we've put together here is just a bit of a visual to try to explain where you may have overlapping care that qualifies under the trigger diagnosis and the claims. We're calling it co-management. In this particular instance, it is where two providers that are providing OB services can both have a claim in the same month and be paid. So to take you through the graphic left to right, we've got provider A visits as the plus and provider B visits as the check. You see in the January-February period, provider A initiates the episode with a triggered claim, and then that carries into them being the attributed provider and receiving the case rate payment for February. In February, provider B, it could be a MFM, it could be another OB, provides a service within that period that causes a triggered move to that other provider. And then both of those providers for the month of February would receive a case rate payment. And then you look towards the end of the month, and whoever is last in chain in that month then receives the continued attribution. So they end up retaining the attribution of the episode. And so it can switch back and forth during the month, but the last performing provider of the month will get the prospective payment. And that you see in the March timeframe, provider B is the only one receiving the case rate payment for that period until April, when provider A provides another service, and then the case rate would move to provider A. We note that in the April period, provider B provides another service. So there again, they have an overlapping service wherein both would receive that month's case rate payment, and then case rate payment for the next month in May is dependent upon the last billing provider, the last service date and billing provider in the month of April to carry forward the case rate payments until if another provider B service were to occur. I think the visual probably explains it a little bit better than I did narrating it. So I'll just give a few seconds to sit with that and digest how that may occur. And then of course we can always take questions. And Tiffany, I see the question in the chat. Is that one we want to answer now, or are we just queuing it for later?
I think we can queue that for later. I might just read a couple questions or comments that I've received so far through direct message. So I have one. If a high-risk patient is seeing a maternal fetal medicine expert for their prenatal care, for example, chorionic twins, will ultrasounds performed by that MFM practice be considered in-house?
So let's put them in the context of provider A is an OB, not the MFM, provider B is the MFM. If they are a qualifying provider in the performance year, then they would receive the case payment along the perspective of the checks. So they would receive an overlapping case payment with provider A if they were coming in and providing the lab services. Under the current state, as we retrospectively assign attribution. The future state, I believe, is designed such that there are triggering codes and a limited set of triggering codes, so that if the MFM wanted to provide the service but not essentially take the case rate, they would provide the CPTs without the triggering code and diagnosis in the future state, such that they would get fee for service and not take the bundle or take the case rate payment at that point. But for now, for attribution and the retrospective look and the dry run that we're doing, that would trigger a move if it's within the CPT and the diagnosis codes.
Okay, thank you. And I received clarification that that was a general MFM care question, not specific to this slide, but I think that's helpful to clarify. I have a comment. Often MFMs remain in a consultative co-management position throughout the pregnancy. So I hope this example helps bring clarification to that. Another question received, in a co-managed case, what happens if provider B performs the delivery?
If provider B performs the delivery, the professional services that are associated, if they are in-house, i.e. if they are an accountable, or if they are a qualifying provider, the professional services associated with the delivery would be associated to your episode and would be included in the reconciliation. As long as the delivery remained with you, it would be included in both your case rate as well as the target price reconciliation process for the shared savings. If the delivery happens outside of what not in-house or happens elsewhere, the claims experience would be included in the case rate, but would not be included in your aggregate target price reconciliation. And I welcome Grace to jump in and correct me if I'm wrong there, or Brad for that matter.
I was going to get less technical and just say, I think in general, how we've tried to set that up is that if you are say in this case, looking here, provider A, let's just say provider A and B are both providing care, and maybe in that provider B is a maternal fetal medicine provider. One is like our goal is to make sure that both providers are getting paid for the services they're rendering. And so a case rate for both providers could be provided each month, potentially, or if, as Charles said, in the future, if the MFM provider is working a consultative role and is not trying to take over the case in terms of being accountable, would bill non-triggering codes and would be able to get paid in a fee-for-service manner for that care. And then in terms of the delivery component, just to say, we very much recognize that there's a lot of times that the attributable accountable provider, maybe in this case, would say A or B, and there might be a provider C or D, and that is to be expected, and that's built in to not change attribution because there's a different delivering provider. So that's more, I took a step back, Charles, so Grace, I don't know if Grace Zana wants to add any more specificity.
No, I think Charles covered it. I don't want to get too much into the technical nuances, but the professional services provided during delivery is definitely an area we've been really trying to nail down and make sure that providers are compensated fairly. And if that is an area of concern, I just want to add that we can certainly write up something or clarifying it further in writing, perhaps that will help. But yeah, that's definitely an area of focus for us.
Yeah, as we've been going through it, we've been making small adjustments to the attribution as well as where the claims cost is associated and applied for the case rate. As we get closer to the dry run, we'll be able to put together specific examples using claims history or claim construct that would give folks an idea of which costs would be associated with their case rate payment and which costs would be in or out of the reconciliation, i.e. which would they be accountable for, which services that they don't perform that would be accountable during the reconciliation.
A couple more questions. One quick one, just clarification of what co-managed pregnancies mean.
In this context, I'm sorry, Brad, if you want to go ahead. In this context, we are describing co-managed pregnancies as those where the episode starts with a core OB that is managing, and then other providers come in to either consult or provide a temporary switch of management, and then it goes back. So not in the context of two in-house provider OBs co-managing, but instead where you have a episode that is managed by two different entities or two different separate provided groups.
Yeah, OB, certified nurse midwife, family medicine provider, any eligible provider who then would be getting consultative care, potentially from I think most commonly maybe a maternal fetal medicine provider.
Yeah, and the thing to note there is that, as Brad mentioned, in the future state, those providers, those qualifying providers that don't seek to actually own the episode or manage the care, will be able to exclude themselves via their claim submission, or include themselves. But given the retrospective look, that's a future kind of coding and claim submission process that'll be detailed at the inception of the demonstration or the bundle.
Okay, another question. For MFM providers, are they able to be considered accountable providers? And would their care be considered in-house?
I don't have specific examples on that, but the answer is yes, as long as they are a qualified provider group and they have over the 30 episode threshold. We are seeing some MFMs in the data. So then in the future state, the MFM will be deciding whether they are the core managing entity, and then their claims would show that. And then they would decide when they are coming in just as a consultative, just consulting, and then their claims would show that, and then that claim would derive a fee for service, not a triggered case payment. And that's of course the future claims state, but that's our intention. So the answer is yes, they can be.
We have a couple more questions, but I think in the interest of time, I might hold these for the Q&A session, if that's okay with folks, just to make sure we can get through the rest of the presentation.
Well, I will be taking over from now for the future several slides. So this section, we're going to talk about target price. So as we talked about earlier in several slides, we mentioned that the case rate, the prospective case rate, are covering a subset of timeline during the prenatal care period. And then there's also the postpartum care that is also covered, subset of postpartum care that is also covered by the case rate. But for the target price, the way I think about it is that we're using historical period to set up an overall episode-based care price for the whole prenatal, delivery, and postpartum care cost. So including the first trimester where we're still going to pay fee for service. So all the first trimester care costs, and then the entire second trimester, third trimester delivery and postpartum care costs will be bundled into this target price as a benchmark for the shared saving calculation. So on this slide here, you can see on the left, there's a bunch of bullet points to pinpoint the services that will be covered in the target price. So in this case, any maternal related care for regardless is provided by in-house or out of the services provided outside of the attributed provider, all those services will be considered as a target as part of the target price. Also, the child education services care or care coordination activities, doula care, all those will be considered as part of the target price. And then just want to note, on the table to the right, the newborn care costs will not be part of the target price for performance year 1. All right, next slide, please. So here we're going to talk briefly about services or the episode in the case where they might receive some care, prospective care, prospective payment, but may not be considered as the final reconciliation episode. So in the first section here, we're talking about some members that because of their own situation, they're not considered as part of the program. So those include members who are under age 12 or over age 55, or mothers that left the hospital against medical advice prior to discharge, or if a member has some substantial gap in their eligibility. So those members will be automatically out of this whole program. But then the second part of this slide, we can see there are certain situations where the members will, or the providers will still receive partially the case rate, but eventually when those things happen, they will be excluded from the case rate, and they will also be excluded from the final reconciliation. So those include some of the pregnancy situation where there's no claim incurred during the first 2 trimesters. So obviously those will not be part of the program. There's also the cases where there's no facility claim for some reason in the episode. We call it orphan episodes. So these episodes, due to the fact that we lose a bunch of important and very costly claims during delivery, we don't want to skew the target price due to those cases. So those episodes will also be excluded from the reconciliation or target price calculation. The third bullet point is basically indicating there are certain newborn cases due to the baby's unique situation, the episode will be excluded from the target price or the reconciliation. All right, next slide, please. So here, we prepared a flow chart of how the target price will be calculated. So first thing I want to highlight that is the target price will pretty much be set on the provider TIN level. So again, similar with case rate, it's not on the individual provider level, but each provider network or based on their TIN will have a unique target price based on each provider group's own historical experience. And obviously the historical experience will be adjusted due to some factors. So in the first box, the green box, we can see the steps will be used to process the historical price to sort of avoid some unique situation. So first thing we'll do is to standardize episode price. So what that means is that for inpatient hospital claims and also some other specialty claims, instead of using the actual cost on the claims, we will be using a statewide provider average hospital service cost based on their diagnosis related groups and severity level to come up with this statewide cost. And we will reprice every single individual inpatient claims to use that standardized price to get to the overall standardized episode cost. So that's the first step. And then we will also windsorize all the outliers. What that means is that we will look at all the episode costs. We will chop up the very low cost episodes and the very high cost episodes. So in this case, we outline the lower bound we said is the 5th percentile of all the episode costs. And then the upper bound is the 99th percentile of all the episode costs. So those outliers will not be thrown away, but they will be capped at 99th percentile and the floor will be set as the 5th percentile. So that's another step we'll use to sort of standardize or process the historical price. Then we will obviously trend the historical price, given that the historic price is based on claims happened 1 year prior to the performance year. So we will take into, the general maybe the general fee schedule changes into consideration. We'll apply a trend onto the historical price we get from the prior 2 steps of processing. So after all of the 3 steps are done, we'll get to this historical price, again, set based on each of the provider TIN level. So after that is done, we will use risk adjustment factor. And we do want to highlight the risk adjustment factor will be based on both the health risk factors, so members, their disease categories, things, basically health related risk factors. We also will be using the area deprivation index to consider each member's their overall area and then their financial and social determinant factors to combine with their health risk scores to get to basically a risk adjustment factor to get the historical price into a risk neutral basis. So basically, if a provider historically has a pool of members that have higher risk scores, they will be adjusted to a risk neutral base to compare against the rest of the providers. So this risk neutral historical price by provider will be used as 50% of the blend together with the other 50% of the statewide historical price to come up with a provider-based base price. And then obviously considering there could be some risk acuity differences between historical year and performance year, we'll use the base price by provider to multiply the actual performance year's risk factor to get to the target price by provider. And again, the performance year risk factor is also going to consider both the health risk score as well as the members' ADI, so the social determinant factors. So all these will be combined to get to the actual performance year's target price for each of the provider TINs. So Next slide, please. I'm sure there will be questions, but I can start taking some after we finish this slide. So this slide is just a little more details on what the risk scores will be. It's basically telling us the risk score is going to, like I said, combine the health risk scores with the ADIs, and then also a higher risk score indicates the potential of members having higher costs. So those are, the risk score higher than 1 indicate a more costly population, and then the score lower than 1 indicate a potentially lower costly population. So I will pause here to see if there's any questions about this part.
And I think given the volume of questions, to make sure I'm not missing anything, I might let people just raise their hand so we can call on them. Make sure we're answering questions in that way.
Perfect. So far, I have not seen hand raised. Oh, here we go. Hi, Nail.
Hi.
Hi.
Hi. Thank you so much for this detailed session. And let me know if this is an inappropriate time or place to ask, but as lactation providers, we provide only lactation. And we're not sure at all how this will impact us financially next year. It seems as if rate schedules are kind of opaque or left to the accountable provider to decide and then do pass through to lactation. Just want to make sure I'm understanding specifically what you all have in mind in terms of standalone lactation groups that will then now be rolled up under this bundled program. Does that make sense? How will the rates be set? Who would be paying us?
Great question. I think
Thank you.
generally, I'm happy to just say, like, in terms of lactation supports, those funds, and it ends up being how it gets broken down is it's $7 per member per month in terms of the additional funding to on top of the case rate, the historical case rate. That is sent to the accountable provider, who does have to determine how to use those dollars, and will be the ones who are determining what level of support providers. We do have a minimum level expectation that members will be screened for need and education, and that those who do need a higher level of care will be provided a high level of lactation care. But that is how it's currently set up, that it will be operationalized through the maternal health provider.
I understand. And just a quick follow-up question. Does this then necessitate us having to have many contracts with these accountable providers? Is it like a three-way Husky and accountable provider and us the lactation provider contract? Or how do you foresee that working in the market?
Great question.
Thank you.
Yeah, so we would not necessarily be so on the DSS side, we would not at this time enroll lactation providers. That would be between the accountable provider and any lactation support providers that are providing it. And obviously some maternal health providers do already work closely with IBCLCs or peer support specialists, et cetera. And so we would defer to there is some flexibility in how providers determine how to utilize this.
So the $7 figure is suggested amount?
That's how much we'll be putting into that providers will get on top of the case rate for lactation support.
Thank you. Thank you so much. That's helpful.
Specific to risk adjustment, I received a question. How are patients with no ADI risk adjusted?
Sorry, Tiffany. I don't know who asked that question, but I will just want to get further clarification. So the ADI is pretty much independent of the health risk score. So the health risk score is strictly based on a claim. Whether a member has an ADI or not, as long as they have claim. Actually, maybe even if they don't have a claim based on their age, gender, all that good stuff, they will still get a risk score. So they're pretty much independent. And they will.
Question. I was just saying it may be a question about individuals who where there's not a definition of an ADI. There are a few areas which don't have an ADI score for various reasons. And when we had talked about it previously, I know we'd said we would take the provider's average risk score and apply it to that member. Most members, when we looked through, did have an ADI score. This is how it was approached through the ACO REACH model. And so it seemed reasonable. And Grace, correct me if I got anything wrong.
Absolutely. I think if the member, sorry, I didn't fully understand the question. Sorry about that. But if the question is about what happened when a member doesn't have an ADI score, I think the best approach and the most reasonable approach will be used as Dr. Richard said, the provider specific average ADI to assign to each of the members within that group that doesn't have an ADI. I think that will be the most fair resolution for that. All right, if there's no other questions on this topic, let's move forward. Okay, so yeah, so in the next few slides, I'll be talking about the reconciliation. So we've talked about the pieces, along the, following the timeline. We talked about the case rate, we talked about the target price. Now, how do we get everything together into the reconciliation part, which is ultimately what we do to determine as the initial, to determine the initial pool of the available share savings for each provider. So the reconciliation ultimately is just to compare the target price that we set for each provider, as mentioned in the previous slides, to the actual cost during the prenatal, delivery, and postpartum time period. As I mentioned earlier, target price is pretty much set based on the 1 year prior experience, and that is used to set the benchmark. And then we want to use that to compare against the actual cost. So the actual cost actually compile both the fee-for-service claim cost, meaning anything that's like, the first trimester fee-for-service claim cost, all the case rate together, case payments together, the delivery costs, all those costs combined during the performance year get us to the actual cost. And then we compare that against the target price. If there is a positive savings, then for the first year, for performance year 1, the provider will potentially get the savings. And then if it's negative amount, meaning the actual cost is more than the target price we set, then the providers will not be responsible for any return of the, for the lack of better term, lower efficiency. But basically, providers will have no financial responsibility for that during year 1, but for the later year that there might be. So I also want to note that this whole reconciliation process will happen no later than 6 months after the performance year ends, and then we will do this reconciliation once per year. But there will be quarterly provider data reports provided to help everybody track the process. And then in the next slide, we'll be talking about the process overall in terms of how it flows over time to help better understand this part. But this is overall the reconciliation process here. All right, next slide, please. All right, so as I said, this is just a slide to indicate how how everything flows over time. In the slide, we just assume the performance year starts July 1, 2024, understanding that potentially it will be shipped to September 1, 2024. Then every data or every time point will be shifted 3 months forward. So just want to note that. But assuming the performance year starts July 1st, 2024, here's how the timeline looks like. So first thing first, we'll use the calendar year 2023 data as the historical period to preset the accountable provider list. So obviously everybody will want to know who are accountable, and they know when there's a trigger payment when there's a trigger claim coming, they will get case rate instead of the fee-for-service payment. So using this 1 year of data is to help preliminarily set who are the accountable providers, what are the prospective case rates everybody will get, and what potentially will be the target price. Obviously, the target price is not going to impact anything really financially, but it will be used to help, with the quarterly reporting to say, hey, so far, how is your episode cost, actual episode cost comparing to the target price we set for you? So it is to help providers track along the way. So the second bracket we can see, so this 1 year experience will be taken to preset all those factors, and that will happen some like 3 months prior to the actual performance year starts, so that we can get at least 3 months of claim run out. So the time period where Mr. will actually preset those information will be during April 1st, 2024 to June 30th of 2024. So this 3 months we'll get all that information we'll be sharing with the providers. Then from July 1st, 2024 to June 30th, 2025, that will be the actual performance year 1. And then again, 3 months later, after the performance year 1 ends, we'll have 3 months claims with 3 months of run out. At that time, we'll actually redefine who are the actual final accountable providers for the reconciliation purpose using that performance year 1 claim information, right? So during that 3 months, Mercer will redefine the final accountable providers. We will redefine the target price based on the actual performance, the prior year experience, and then we'll do the target price calculation, and we'll calculate the final share savings. So all the providers will get the final results by the end of by the end of 2025. So that's an overall timeline, assuming the performance year 1 will be for fiscal year 24-25. Just want to pause to see if there's any questions before we move on to the quality measures. Okay. Nothing so far, so let's move on. Okay, quality measures. So, all right. So here, yeah. That's
I'll take this one. Thanks, Grace, so much. So we want to provide an update. Some of you may recall that one of the quality measures in our quality program was the maternal adverse events measure, this was discussed extensively. It was a measure that was it's a modified measure from a measure that was developed by Yale Core to measure hospital morbidity plus maternal mortality occurring during the delivery hospitalization. And it used data from the electronic medical record to calculate that. We asked Yale Core to convert that to a claims-based measure, which they were able to, and there's 30 risk variables included with it. But we heard a lot of feedback from various providers, and we wanted to make sure we listened to that. We heard that based on the measure is created for measuring the quality of hospital labor and delivery services, focused on conditions that are heavily influenced by hospital clinical care protocols, and not developed for the purpose of addressing the quality of care delivered by community OB practices. We took that, we thought about it extensively, had multiple conversations about it, and we are recommending, planning on making some changes that we've brought already to the advisory council. But the considerations that we have at DSS for evaluating the provider feedback as well as the measure further was that we know there's a disproportionate impact of maternal adverse events have on birthing people of color. That there was an importance and support from the advisory group that placed on this goal in the past. Yale Core, which developed the original measure for CMS, had modified it for DSS and is assisting with its implementation. And the measure is risk adjusted and accounts for a small number variation at the provider level. So what we've recommending and what we're planning on doing is adjusting the impact of that measure. So it was going to be 18% of the quality score. We're going to plan to reduce it to 6% for the first year, with the aim of further validating the measure and eventually increasing the importance of the measure in the future, pending further measure refinement. And so we just wanted to bring this here. We had an extensive conversation about it with the advisory council itself, and wanted to bring this further. And so I'll pass it back over to the Mercer team. To review kind of the adjustments to the overarching qualities, the percentages on each of the quality scores, and how some of the updates to how we're thinking of the quality scores will impact shared savings. Grace, I think.
Sounds good, thank you. So next slide, please. Yep, so here we're, as Dr. Richards mentioned, that we used to have maternal adverse events way higher than what we're seeing here. Used to be 18%, but we lower it to 6% due to other, considerations. So correspondingly, we actually increased the C-section birth weight from, I believe, 18% to 24%, and also postpartum care from 12% to 18%. So here is our final sort of weight for each of the pay-for-performance measures, as well as the pay-for-reporting measures. So we do want to note, as the first 5 are the pay-for-performance that combines into 71% of the total weight, and then the pay-for-reporting 5 pay-for-reporting measures combined together is 29% of the overall weight of the quality measures. Next slide, please. All right, so here is sort of a flow chart of the methodology we use to decide the final score, which indicates how much percentage of the potential shared saving amount each provider will be getting. So it is 2 steps. So we have the left-hand side shows the performance tier calculation. So basically what we do is that we look at each of the quality measure results for the performance year. We compare that against the range for that particular quality measure in the prior year. Let's say the prior year, the C-section rate among all the providers range from 10% to 15%. So that will be our benchmark for the prior year information. Then we use this year everybody's C-section rate, compare that against that range of 10% to 15%. Then we find each provider's their placement over that range for that measure. So that is how, and then obviously we inverse the ones where a lower percentage means better performance. We inverse that, use 100 minus the results, because we want to make sure across board every single measure has a higher score, meaning they have a better performance. So that all the measures are on the same basis. So all those steps will be taken. Then we will we'll use the weight we showed in the prior slide to combine all of the quality measures result into one final score. And that score will be used, and then there's in the next slide, there will be a chart showing, when your performance is 60 percentile of, the tier, what will you get as the performance tier result? Okay, and then the performance tier results range from the final score range from 50% to 100%. So we try to make sure there is a wide range. So, good performers can be recognized and can be compensated accordingly. So 50% to 100% is the range of performance tier scores. And then on the right-hand side, we'll see the improvement tier calculation. So what we do here is we actually look at 2 years. We look at the prior year's overall score using only the pay for performance measures. So only the 5 measures on the top. So we use that 5 measures results together. We calculate the current performance year results. And then we also calculate the prior year results. Then we compare these 2 years and see whether things have improved over time. Then that percentage of improvement also will be compared, and into that chart we'll be showing the next slide to result into a improvement tier score. And those 2 scores, the performance tier score and then the improvement tier score, will be compared, and we'll use the maximum of those 2 to get your final share saving percentage. So that's kind of how we're going to run this quality measure, and then we will use that to reflect the final share saving amount. So Tiffany, do you mind to go to the next slide? All right, so those two tables on the right-hand side is exactly what I was talking about. So if for the performance tier score, if you're somebody, if a provider is under 55 percentile of your peer group comparing to, the prior year benchmark, you get 50%. And then, as 55 to 60 percentile, you get 60, so on and so forth. But if a provider gets higher than 80th percentile of the peer group, you get 100% of the performance tier score. Then it really doesn't matter the improvement tier score, because we take the max, you will get 100% of the shared saving. But also reversely, if a provider's performance tier score is not the best, but they have improved tremendously, then they will get a high improvement tier score, up to 90%. And then overall, you will get 90% of the final share savings. So that's how this is considered in the range. As we can see, the range is pretty wide. The performance tier score goes from 50% to 100%. Improvement tier score goes from 50% to 90%. All right, next slide, please. So we did actually use the historical experience to calculate currently what the provider's performance look like. Based on the refreshed measure, like weights and everything, we calculated and we summarized here in this chart. So the first bar, the top bar here is what we calculated as the performance tier score, and then the percentage of providers that get each of the score. As we can see from left to right, it ranges from 50% to 100%. And majority of the providers get, actually 50% of the providers get 70% of the performance tier score. For the improvement tier score, majority of the providers got 50% of the improvement tier score. And then comparing those two, obviously we took, like I said, we take the maximum of those two scores, and then overall we have quite a even amount of providers getting scores ranging from 50% to 100%. Right. So I will pause here to see if there's any other question about quality measures.
Grace, I know we have a bunch of questions. I know that we'll get to at the end. I'm not sure there's seen any further about quality measures yet, but
Okay.
Great. Tiffany, do you have a preference or how we handle it on this? Do you want to just keep them to the end at this point?
Yeah, I think we have one or two more slides, so we can hold off until then.
Perfect. All right. So Charles, I will hand it back to you about underutilization plan.
Yeah, and actually on this one, I was going to partner with Brad. This is a plan of action that we have derived for all of the shared savings programs in the state of Connecticut. It's just a plan to retroactively look at the claims and how the claims have changed to try to identify any aberrant behavior or any type of pattern that causes us to believe that there's any type of withholding of care or stinting or regression of any type of service that was trending in a specific direction. It allows us to take a look back and then further drill in. Each situation is going to be composed of several different factors, including what provider types, where the service happened, things like that. But the underutilization plan, as outlined here, just allows us the opportunity to go back at the end of the performance year and look at what changed year over year to see if there's anything that we need to drill in, to see if there's any type of cherry picking or preferential treatment that's occurring in the system. Brad, I'd let you just add to that.
Yeah, happy to just say, I think in addition to kind of, Charles, what you just outlined is some of these other pieces that were already discussed is that clinical and social risk adjustment to really try to mitigate, to incentivize providers to actually want to take care of folks that actually have more complex needs. Additionally, carving out specific services from the program, such as mental health and SUD services, LARCs, vaccines. So just things that we don't want included in that as part of this, and will continue to be paid separately and kept out of that cost of care calculation at the end of the retrospective reconciliation. And then also really trying to drive towards these quality measures and making quality scores and quality measures a really important part of the shared savings, so that people aren't just focused on costs, that we really have a quality framework that goes hand in hand. We think as part of this that reducing some of the unnecessary costs around high C-sections, avoidable C-sections, as well as some of the maternal adverse outcomes that we hope increasing some of that potential coordination in the preterm time frame will help reduce some of those downstream costs that we think are win-wins across the board. Good for providers, good for DSS, really good for our maternal health members, our pregnant members. And then the time frame of the bundle, really hoping to increase the accountability that providers providers I know want to feel accountable. We haven't always incentivized providers to feel that way, and we're hoping that moving this direction will help with that feeling of accountability that I know providers want to take on but haven't always been incentivized to do. So and I'll just say we'll have more specifics about some of the underutilization plan in the future, but this is kind of the framework for how we're operationalizing. So I think we'll take next steps and questions. And I wonder, does it make sense to just go through this quickly, Tiffany, and then we'll take some of those questions and run through them. But just to say kind of what's next, we highlighted this a little bit at the beginning, but just as a reminder, it's really finalizing CMS, the state plan amendment approval process, getting that submitted, actuarial modeling, and program readiness. So we know that the upcoming work is getting some of you the significant details on this bundle, including what the case rates are for providers, how would you perform in a historical period of time using that dry run from 2022 claims and giving you reports off of that. And then we'll plan on having additional forums and advisory councils. I'll just note there's a bunch of resources that are listed here. Please make sure to check those out. As noted, we will resend out the slides, and you will be able to access the materials on the DSS website, as well as the video recording that will post, will not be posted quite today, but will get posted on the CTDSS YouTube channel. So we can jump into some questions. I know I have some of them listed, Tiffany, and I'm happy to read through what I have. Charles and Grace, some of them may ask for some of your input on, but I'll take first stab at most of them. So one of the first ones was, I have 3 pediatric MDs that are on call for maternity at a hospital. We're not employed by them. Does this bundling pertain to us and our reimbursement? So right now, pediatric and newborn care is excluded from the bundle, though we will be monitoring that. And so pediatric claims for the newborn would not be included as of now. However, as noted, we are interested in including newborn care in the future, and some of that accountability would be on the maternal health provider. So Grace or Charles, anything else you want to add to that? Okay. The next one is about risk adjustment. Will the risk adjustment formula be transparent? I.e., will we be able to see how it is calculated? Grace, do you want to, or Charles, want to tackle that one?
I think, Dr. Richards, I don't feel like we have internally discussed whether we will share the exact formulas and all that, but obviously we'll share the logistics, but we might need to take it back and discuss further to see if we want to share the full-on formula.
Yeah, sounds like a good conversation. Sorry, go ahead, Charles.
I would just mention that we've covered that on other programs in 2 parts. One by outlining the process and the algorithm that we use and apply. That'll be a detailed kind of description of how the methodology is occurring. That's also included in the federal approval documents. And then at the end of the calculation, we'll prepare a package for all participating providers that will essentially take them through the math of how it's applied. Whether the actual risk, the risk score, or how that's derived will probably not be included, as that's the health social risk score comes to us from CHN as part of the Johns Hopkins model. So the actual kind of derivation of the risk score is kind of blind to us in that process, but we do outline where it's applied in the process.
Great, thank you both. And I'll just note, in general, we'd like to be as transparent as we can with this process to make it as easy as possible for providers to understand what we're doing. We understand that helps generate, trust when we are transparent with the information that we're talking about. So it's a general goal for us to do. I see a hand up. If I will maybe try to get through some of the questions, and then we'll go to some hands too. I just want to be mindful that I know folks submitted some of these questions early on. Has there been, I'm just going to read the next one out loud. Has there been a provider impact assessment? See how this will impact the lactation groups in the market. We anticipate having to pull out Husky patients of $7 PMPM for all lactation care for a member. Just curious whether an assessment has been conducted as the impact in provider supply for the shift in payment, given the Husky is a single payer. So we're not necessarily changing. This is an additional payment for providers. We're not necessarily changing how we've paid for lactation support. With that said, we don't enroll currently IBCLCs as direct, as enrolled providers within Husky Health. So with that said, this isn't additional to what we're currently doing. This isn't necessarily taking away from any other payments in terms of that $7 a PMPM. Our practice is required to submit charges monthly, how our dollars follow through the pregnancy. So we are working with CMS and have some conversations about the requirements. We anticipate providers will continue to need to submit claims throughout the pregnancy to monitor utilization, even if they're receiving the case rate. Those will be zeroed out claims if you're an enrolled provider. So for example, the first trimester, let's say I'm a certified nurse midwife, a member comes to see me, I submit claims for that first trimester. Those would get paid fee for service. Starting the second trimester, if there's a triggering trigger codes are billed, I would start to receive that case rate on a monthly at the end of the month. But as I'm seeing an individual, if I see them in the practice or I do a televisit and that's a billable service, we would expect that to be a submitted claim that would reimburse zero. There'll be a list of of claims, CPT codes that will get reimbursed zero amount, and we'll make sure to, as we're finalizing that, publish that so folks can see it. So the dollars will flow in the first trimester fee for service. Subsequently, for those maternal health providers that are part of an attributable provider would get that case rate at the end of the month related to the care that they're providing. Charles or Grace, anything you want to add to that?
No, that's pretty comprehensive. That's about right.
Okay. If a MD OBGYN is providing only prenatal care and doesn't deliver any of their patients, babies, how is this paid? So if it's a provider that's attributable, we definitely have considered this. So to be an attributable provider, you don't have to do the delivery. We understand there's a lot of OB hospitalists, et cetera, of different provider types. And so to be attributed as a provider does not require that provider or anyone in their TIN, their provider group, to perform the delivery. I'll leave it at that. Hopefully that helps kind of clarify that question. Anything else, Grace or Charles, you'd want to add on that?
No, the attribution process allows crediting of the episode to the most responsible OB or licensed midwife, any eligible provider.
Let's see. If the bundle payment will be utilized under the new coverage option for undocumented pregnant and birthing individuals. We should double check that in terms of coverage, but I will say I believe the answer is yes. If they're covered under Husky Health, this would apply, but we can take that back and confirm that. But my understanding would be it should be for our coverage options, including under the unborn child option for CHIP. But we can confirm that. That's a great question. When will we receive the reconciliation payment? Will the dollar amounts be specific for those other services such as doulas and lactation? At least on the maybe I'll just say on the doula lactation. So for providers that are attributable and that are getting a case rate, there is an additional amount the lactation support, additional lactation support dollars is $7 in PMPM. The doula portion is $14 PMPM. There is, on the reconciliation portion, we have said that those lactation dollars are not at risk, meaning we would not take them back. The doula dollars are at risk. What that means is for a provider that may, if they choose not to work with a doula, that $14 at the end, if there wasn't a doula utilized underneath the bundle, so they could be used separately. They could be, if there's a fee-for-service billing that could be happening outside of the bundle, we would take that, the $14 PMPM back because it is at risk. We're encouraging doula participation and utilization. We'd love to see providers work with doulas. We're happy to have providers enroll. We think that's a really important part of the improving the outcomes for maternal health in Connecticut. Let me pass it over in terms of when to receive the reconciliation payment. Grace, I think you covered this a little bit, but do you want to maybe just add any other specificity?
Yeah, so I think the reconciliation and then the final results in terms of what's the, the potential share saving and what's the quality measures, those will all be calculated, prior to 6 months post the end of the performance year, in terms of how when exactly the payment will go through. That is, independent. That will obviously be after that, but that's not something that we will have too much information on. But the results in terms of the how much each providers will get, just like PCMH Plus program, will be shared that results within 6 months post end of performance year.
Thanks, Grace. Last written question that I have is following up with the lactation issue. If we give care for 8 months to a patient, we get $56 to support lactation. Is that correct? So on a per member basis, that's correct. I think as we've conceptualized it as of now, that some individuals, basically everyone needs a screening for needing additional support for lactation support and basic education. We think a lot of that that basic information is being provided now. Some people need a higher level of lactation care. And I will say one thing that maybe didn't come up here, but we've had to say in other forums is that as it had a limited pool of dollars in terms of allocating to start this program. And so we had to make a determination about how we're going to allocate those resources, the limited resources that we have for lactation and doula support. And so because of how we've structured the program, we did put a little bit more of the resources towards doulas than to lactation support. Not to say that lactation support isn't extremely important. We recognize the importance that lactation plays for both the birthing person as well as the newborn, but we had to make difficult decisions and have landed on a slightly more allocation to the doula resources at the go live. We are interested in having conversations about further supporting lactation support in the future, but I just want to make sure to say that out loud in this forum. We've said this and we've said that in other forums, including for the advisory council previously. I think there was a hand up. I think Colleen had a hand up before, and we just ran out of our questions that were written. Tiffany, or at least the ones I had. So Colleen, if you're still on, wanted to allow you to make sure we got a chance, you got to ask that question.
Yeah, so
Ooh, Colleen, I'm not sure, I lost you. I can't hear you. Did others as well?
I can't either.
Colleen, do you want to try again? If not, feel free to type it.
Can you guys hear me or no?
Not super well. Maybe a little bit. You want to try one more time, or feel free to type it in the chat and we can try to answer it that way. So not hearing you, Colleen. If you want to try to type it, if you send it to Tiffany, we'll make sure that we answer it or try to get to it. And Tiffany, do we have any other written questions that I missed that you noted?
Not that you've missed, but one other did come through. Are there other states that have implemented a similar bundle with this structure? What have the outcomes been?
It's a great question. I will say we haven't looked at this since, or at least on the DSS side, we haven't looked at this since 2021 when we first started working to devise this. I would say this is a fairly unique structure compared to other states. But I also know that other colleagues may have more information about what's been happening since 2021. I know some states have been reworking their maternity bundles that they developed previously. Charles, I don't know if you want to weigh in. I think you may be more plugged in more recently.
Tennessee.
We could take that back and perhaps for the next forum put together a kind of state of state. I'd rather not shoot from the top of my head.
Yeah, no problem. If you're no worries, just wanted to give you the
more recent. Yeah, I think recently the programs have been simplified across the country in terms of the complexity, and I think we're realizing that that may be because the complexity of implementing it with different types of strategies is a little bit too much when it actually is on the ground. So I think what we are going to end up with is a combination of kind of what is happening in the landscape, which is a simplification of it, while retaining some of the principles that Connecticut started designing with. But we can certainly put together a kind of state of state or a high level state of state for the next presentation.
Sure. Any other ones?
I got Colleen's question. When can we expect the details for billing and payments? Will the case rate payments come through the standard remits?
As soon as we can, I think is the answer in terms of when we want to get them to you. I know the Mercer team has been working extensively, tirelessly to try to get, and just for a little bit of context, we've, on the DSS side, for those who haven't been involved since the beginning, Mercer is kind of our new actuarial team member. They're not new to DSS. They work with us extensively on tons of various programs. We know them extremely well. We initially had contracted with another vendor that unfortunately their unit got shut down. We had some subcontracting work that was done through this last February. And as we've revisited some of that work, some of it's had to be reworked and redone. And so we are in the process of doing it. So it has pushed our timeline back on the DSS side because of that. And we are working to get that. We were hoping to have some of this to you already in terms of those case rate, have the case rates out. We know that's really important to providers to understand what that looks like and to be able to ask questions. So just to say, in the works as soon as we can. Charles, do you want anything else to those other parts of the question?
No, I would just say that by the time the program goes live, whether that outside date is September 1, 2024 or sometime sooner, by that point we would have specifications on the code list that's included in the prospective payment. We would have the attribution nailed down. We would have the target prices and the target prices and the case rate payments out to each eligible provider group ahead of the performance year. At some time, hopefully prior to the 9/1 date, if it ends up being the 9/1 date, we'd have a full dry run that would give you kind of a trend line of performance to base your prospective interventions or kind of program launch or revisioning how you manage those episodes. The dry run by that time, I'm not sure we can commit to, but hopefully there will be enough time that is, if it's 6/1, we may get everything but the dry run and that trend line for you until Q1 of the performance year. But definitely prior to go live, you would have all of the specifics on which codes are included, how much the case rate is, how much the target price is that you'll be going into the performance year with.
Thank you, Charles and Brad. Another question came through. Will the appeal process be the same as today? The claim appeal process.
The claim appeal in terms of claims specifically, or I wonder if the question is more about retrospective reconciliation claim.
Good question. Bernadette, do you want to unmute yourself to clarify?
I would just say in terms of our specific claims process for kind of your traditional fee-for-service claims that there's no plan on making any adjustments there. Charles, I don't know if you want to comment on, I know we're getting close to the hour, but just to say adjudication for retrospective reconciliation and how we've handled that in other cases.
Sure, in other instances, as I mentioned, we prepared a packet that shows the math of it, and by that point, we're using adjudicated claims. So the process for claims appeal would have been resolved by that point. We get it. If there's any question in the data that we used or how we use the data, we have in the past sat with the individual provider group and talked about the results that we found post calculation. And then if there was any tweaks needed, you know, a misassumption or some missing portion of data, we can go back and correct. But that opportunity to do that or inform that process is the 6 months after the close of the performance year. And there is always a period therein we're socializing the results before the shared savings remittance happens.
Thank you. Maybe anything else?
That's all that I have so far.
All right, well, we appreciate everyone joining. So we have a lot of folks that are on, and just to say, we are committed to working on this program. We know it will continue to require some refinement post-launch, and we'll be looking to continue to engage both with broader prior forums as well as with our advisory council committee that we have, and we'll be looking to schedule some follow-ups as we have more details to share and discuss with you. So thank you all again for spending the time with us. And we're really excited about the possibilities that this could lead to some improvements, especially for birthing people of color. And we look forward to partnership and continue to engage. So thank you all.